Uh, yeah. But yes, so hello to everyone. We're starting with a bit of a small group. So I initially hadn't planned on doing any kind of introductions, but we may have a small ice breaking since we have such a small group with us, just to get to know everyone. But yes, my name is Cade Arnink. I am the lead trainer for today, and today we'll be joined by Fletcher Herring and Evangelina Moralez-Norris, though, and yes, there's Fletcher, he's joined as well. And yeah, so we are all members of the Southwest CTN. We're here doing behavioral health research with the University of New Mexico on a variety of different studies. And on top of that, we are all members of the Motivational Interviewing Network of Trainers. I've been a trainer for 6 years. Fletcher is coming up on his third year of training, and Eva will be going to her training for new trainers next month in Minneapolis. So we're very excited to have you here with us. Um, and sorry. And so yeah, just as we get started, just want to go over some norms and expectations for today. Um, you know, just off the bat, come with an open mind. This is being billed as an advanced training, so I expect that everyone here has some familiarity and experience with motivational interviewing. And so as we discuss things, there may be things that are different than how you've experienced them, or maybe new or familiar to you. Whatever we discuss about, just try and come with an open mind, see what you can learn from it. And, kind of my hope for today is that you take what's relevant and leave what isn't. And then also, so this training will be structured. We're going to kind of present a lot of information up front, and then we'll do a short break. And then the back half of this training is going to be all experiential, all participation. So be ready then to participate and really experience this. And our main framing for today is going to be around finding hope and confidence and how we can evoke that from people and really bring that to the forefront of conversations. I always like to remind people that MI is a specific tool among many tools. As I said, take what you can, leave the rest, see how this fits in with the work you're already doing, how you can utilize it, and just really let it work for you. I encourage everyone to ask questions as we go. You can jump in and interrupt me or put your questions in the chat. And then also just a quick note on Zoom etiquette. Life happens. We're all here on our screens. So, as you need, feel free to get up and go. Just make sure that when you're not talking, you're on mute. And then when we do get to those portions of experience, like that is where we do prefer cameras on and full engagement, but I'm not going to require anything like that for the whole time. Just really in those moments where we need to be working with each other. Whoa, and it just jumped to the end. I don't know how it did that. Quick run through of the entire training. But yeah, and so our goals for today, we'll be defining hope and confidence and understanding their association with treatment outcomes, discuss how MI can be reworked for limited time settings. We'll be exploring different tools for evoking confidence. We'll practice evoking confidence, and then we'll have a brief note on how we can go from confidence to planning. And so just kind of to start us off, we're not going to go too in depth to it, but just to make sure we're all on the same page, just going to do a brief overview of what is motivational interviewing. And very briefly, I'm sure many of us are aware, motivational interviewing began here in Albuquerque, New Mexico in the early 80s during discussions on treating patients with alcohol use disorder. They were observing the ways in which providers spoke to patients and how patients responded, and how this contrasted with the authoritarian style that was really dominant at the time. Um, and so when we talk about MI, we want to talk about it as I talk about it as this style of communication. It is collaborative and goal-oriented with particular attention to the language of change. It's designed to strengthen personal motivation for and commitment to a specific goal by eliciting and exploring a person's own motivations for change within an atmosphere of acceptance and compassion. MI itself is not a specific intervention. It is a way of being, how we show up with people and how we engage in this style of communication. And it can be used with other interventions, moving in and out of MI into other different modalities, techniques, whatever things you're doing. And when we talk about MI, we always like to center in this place of it is a guiding style of communication. This sits between a following style, which is good listening, very Rogerian, where you let the client lead everything. And it also sits between directing, where the provider is the expert, is giving information and advice. MI sits there right there in that guiding in the middle. We are coming alongside people and working together to and collaboratively to find that change by drawing out their own meaning, importance, and capacity for change. Um, it's important to note that MI requires the provider to engage with the client as an equal partner and refrain from unsolicited advice, confronting, instructing, directing, or warning. It is not a way to get people to change or a set of techniques to impose on a conversation. Again, it's this way of being. It's something that takes time, practice, and requires self-awareness and discipline. Um, and also, MI is not a one-size-fits-all solution. We want to use MI when we see people have high ambivalence, when they're stuck in those feelings about change. When we see low confidence, people doubt their abilities to change, which is where a lot of our conversation today is going to focus. When desire is low, people are uncertain about whether they want to make a change, and when importance is low, and the benefits of a change and the disadvantages of the current situation are unclear. And to kind of all summarize that, there are three essential elements we can think of when we talk about MI. There's the focus element. MI is a particular kind of conversation about a specific change, not a general change. We want a very specific change goal. There's a relational aspect. MI is client-centered, so that spirit of MI, empathetic, partnership, honors autonomy, not expert recipient. And the technical aspect of MI, it is evocative. It seeks to call forth a person's own motivations and commitments. So that brings us very nicely to always good to remind people about the spirit of MI. These are the things that if we're not doing these things, it's not motivational interviewing. A lot of the techniques and strategies we'll discuss can be used outside of this framework. With everything we do, we want to be within this spirit because that is kind of what makes our presence, our way of being, motivational interviewing. And so that's partnership, that autonomy support. Really, it is a collaborative. The client is the expert on themselves. They know themselves better than anyone else. We really want them to be leading the change process. Evocation, we're working to bring forward people's own motivations to change, not telling them how they should change. That compassion element, we are supportive, affirming. And then the acceptance, really honoring people's absolute worth and practicing that accurate empathy, you're trying to understand people, as we make reflections and respond to people, just really trying to show that we hear them and are trying to understand them. And then for today, we're really going to focus almost exclusively on the evoking process of MI. So all our conversations will kind of be held within there. So really on those different techniques and strategies we can use to bring forward more confidence, more hope, more commitment to change. And oh, what is going on? I am so sorry. I don't know why it keeps doing this. Does everyone see it again? Did it pop back up?
Yes, I see the title page.
Perfect. I don't know what I'm pressing where it's just skipping to the very end. So yeah, and just quickly, just going to talk about this idea of ambivalence. Again, stuff we're all familiar with. So people who are ambivalent are going to have motivations on both sides of change for favor and against of it. We're always going to hear both sides of that change talk, statements about supporting the change, and then sustained talk, statements against the change. And it's really important, especially for our conversation today, that we know what kind of language we're hearing, especially what kind of change talk we're hearing, so then we can use the strategies we're going to talk about to focus in on the different kinds of change talk we're hearing and really expand those conversations and draw out what we're interested in hearing from people.
Okay, so what are the types of change talk? In the world of MI, we utilize the acronym DARN CAT as a mnemonic device to describe a lot of different types of change talk. So DARN actually represents a desire, an ability, and a reason and a need for change. And these types of change talk are actually fit under the category of preparatory change talk because they're indicative of a client's motivations for change without them overly stating or implying specific intent or commitment to acting on that change. So a client is showing us preparatory change talk when we hear them express a desire for change, which can be expressed in statements about wanting something different. For example, I want to find an AA meeting. An ability to change, so statements about self-perception of capability, like I could start going to AA. A reason to change, which is an argument for that change, like I'd probably learn more about recovery if I went to AA. And then finally, maybe a need for the change. So these are statements about importance and urgency, like I have to stop drinking. CAT represents a commitment, activation language, and taking steps. So this type of change talk is usually indicative of mobilizing change talk, so more action-oriented language. It refers to a change talk that expresses or implies an actual action toward that change. So when a client is giving us mobilizing change talk, we'll hear them express a commitment, which is a promise or intention toward making a change, like I swear I will go to an AA meeting this year. An activation statement, which show a current movement towards change, like I'm ready to cut down on my drinking. And then finally, some steps that they may have taken. So these are statements indicating that the client has already done something to change, like I avoided a party where friends would be doing drugs and drinking. You can go ahead to the next slide, please. So simply spotting a patient's change talk isn't MI. That alone really doesn't facilitate a meaningful life change. We want to recognize the type of change talk a client is using, preparatory or mobilizing. And that can really help us choose our responses intentionally with the goal of steering the conversation towards increasingly action-oriented change talk. So in an addiction setting, not everybody's ready to make a change and not everybody is even ambivalent. So they might have little confidence, maybe due to a relapse that they had in the past. Whatever the case may be, it's why it's important to listen to what they're saying so we can really hone in on the things that we need to evoke and encourage. So if we're just hearing a little bit of that preparatory change talk, that might indicate that the client has really low confidence or low motivation. And that would be something like pre-contemplation. They haven't really thought about making the change and what that would actually look like. So when we start to engage them a little bit more with that action-oriented talk or evoke more of that action-oriented talk, then we'll see them reach that contemplation and really start thinking about how this change might impact their life and the things that they can do to move forward. And the goal is to encourage and evoke enough mobilizing change talk that we lead to an action toward that change.
You, Eva, and it's important to note that, especially within addiction settings and substance abuse, that not everyone is always ready to make a change or even ambivalent. And in these cases, MI can be used to help people build up readiness, help them actually move into that ambivalence, and then kind of start that process all over again. So you just want to be aware of where people are at in this whole process. If we move into that commitment language too quickly, it can be more damaging than not doing anything at all. So we really just want to meet people where they're at, and really recognizing the level of change talk we're hearing is what will help us do that. And then a quick note, this is going to frame the rest of our conversation on working within limited time settings. As Dr. Miller and Dr. Rolnick, the founders of Motivational Interviewing, have revised their thinking on MI and consolidated the growing depth of research, they've started promoting this idea of MI as a way of being. Instead of thinking of it less as this specific intervention you're doing, it's how we show up with people and how over time, through many conversations, we use this guiding style of MI to bring forward people's own reasons for making a change. And so there's often a lot of assumptions that MI is something that takes a really long time, that we're spending multiple sessions with people kind of getting at this idea. But MI is highly flexible because it is a conversation and because it is, and as long as we're staying within the spirit of MI, the actual use of MI looks very different amongst different people and how we use our own, bring our own styles to it. And so if we thinking about MI as something that is more flexible, we can start to think about MI as another way. I think a good analogy is we can think about how we use medications to help people. You can receive a small dose of MI, just a few minutes, or a larger dose, an hour-long session, multiple sessions. But the ultimate goal, regardless if we have a couple minutes or lots of time with someone, is that our goal is to still move people towards their change goal. And whether that's a lot or a little bit, even small doses can have big impacts on people's motivations for change or their hope and confidence, which we'll be discussing today. And all the strategies that we'll be discussing today can be part of larger conversations, or they can be used in situations where you only have 10 minutes or less to really get directly at these points of hope and confidence. If you're noticing that that's something that a client is lacking, that you would like to help them with, but maybe you only have a few minutes, all these techniques can be used in really like isolated settings. And so there's a lot of different ways to think about how we use these. And maybe in those limited time frames, we can't use amazing, perfect motivational interviewing, but we can still have collaborative communication where these strategies can help us help the people we're working with. And so, yeah, I just really just want you to keep in mind that nothing has to be perfect. There is no expectation of having this big, beautiful picture, this all the time in the world, but that these things really can be used in these microdoses to help us get to the core of what we're trying to discuss. And so that brings us to finally talking about evoking hope and confidence. So initially, MI was conceived as a method for evoking motivation to change in situations where the importance of change was more apparent to the counselor than the client. And it's likely that a lot of the trainings you may have attended before have focused almost exclusively on how to enhance clients' perceived importance of a change. And so we really want to shift that today to talking about like, what does low confidence look like? How do we bring forward hope? How do we bring forward confidence talk? How do we strengthen commitment language? And so kind of starts with like, what does low confidence look like? These are just some examples. I could get a better job if I got a college degree, but it's been a long time since I was in school and I don't think I could keep up. I know that smoking is bad for me, but I've tried to quit several times and I just can't seem to do it. We definitely need to communicate better, but I don't think my family is really committed to trying. I would like to stop using fentanyl, but the withdrawal is too painful. And I'm curious, what do we notice about each of these statements? What do they have in common?
It reminds me of my favorite analogy, which is from Pee Wee Herman, where he says, "Everybody I know has a big butt."
Yes, and I'm seeing that in the comments as well. Each of these statements has a but in them. And Cheryl as well, the other part, each of these statements start with a desire or a mobilizing change talk. So we're in that darn side of the darn cats. So yeah, we sometimes hear these statements where the importance of change is evident, but there is this sense that it cannot be done. And so that's what we really mean when we're seeing low confidence. So to start evoking that, we start with this idea of hope, which is the belief that change is possible and we can lend hope when clients are short on their own. And on the side of that, confidence then is the belief that not only is change possible, but I can contribute to making it happen. So motivational interviewing is about activating personal change, evoking clients' own beliefs that change is possible. And why would we think that a lack of confidence would be a barrier to change? What have you seen with people that you've worked with? Yeah, lack of resources, previous relapses, shame from not succeeding. And yeah, that's both those get to, especially within substance use, failure, like previous instances of failure can be really damaging to low confidence, really giving into that belief that, yeah, the shame that this is something that's not possible. Um, and sometimes these can get so bad sometimes that low confidence can even affect the importance of change. If you don't believe change is possible, why would you care? Yeah, isolation, that's having that low confidence, having that lack of sometimes be lack of connection, having people not reach out and get that support. And we can instill the importance of change, but if clients believe that it is beyond their reach, this can lead to feelings of distress. So, really wanting to try and support and bring forward these feelings of confidence. And the research shows that people are unlikely to commit to making a change if they lack confidence in their ability to do so. And so we can kind of end up with four different types of clients. Now things like this are never perfect. People don't fit nicely into neat little boxes. Um, but we can generalize to broad generalizations of clients. So we've got high importance, low importance, and high confidence and low confidence. In situation one, where confidence is high and importance is high, this is the ideal. This is when people know change is important and they're confident they can accomplish it. And for these people, professional help is not very likely to be needed. Situation two, it's where we have low importance and high confidence. This is where the belief that change is possible it sounds like I could do it, but may not perceive it as important. Sounds like, why would I want to do it? This is the situation where MI really began in. It's seeing those early patients in the 80s and kind of what it's grown from. Situation three is a lot of where we're going to be talking today, where confidence is low, but importance is high. And this can be a demoralizing place to be for people, even if it's only temporary. Um, this may sound things like, I'll try, but confidence can be so low that people aren't even willing to try to make changes. And then finally, situation four, where importance is low and confidence is low. This is the least ideal situation. This is where change is perceived as neither important or possible. And so this is, a lot of work is going to be required, you know, where we may not even see ambivalence. And so this is a situation where you can still use motivational interviewing to move people into that state of ambivalence. So they're not even on that stages of change yet. But again, we'll mostly today be talking about people who fall under that third category. And then also just a brief note on substance use. Like, why is this so relevant to substance use? There is a large body of research demonstrating the importance of self-efficacy as a predictor of treatment outcomes. Back to Bandura in 1977, he conceptualized self-efficacy as the belief that one can successfully execute behaviors needed to produce a desired outcome. And MI has always kind of prescribed that it addresses self-efficacy, but early on there were criticisms that there were unclear instructions about how MI could accomplish this. Since 2002, kind of a lot of the research into MI has shifted into addressing this. And so a lot of what we're going to be covering today is kind of what has come from a lot of this work to say, hey, here is how MI can address self-efficacy. And then we know things like people with high self-efficacy are more likely to resist situations of high-risk drinking or drug use. And in the case of a slip or relapse, people with high self-efficacy are more likely to view it as a temporary setback. There's also evidence that shows self-efficacy is a predictor of quality of consumption for up to 12 months. So people with higher self-efficacy have lower rates of substance use than people with low self-efficacy. And then it's also a strong predictor of abstinence and relapse. So higher self-efficacy, we see higher rates of abstinence, and low self-efficacy, we see higher rates of relapse. And then just a quick note on Project Match, which often gets brought up a lot in motivational interviewing training. So people may have heard about Project Match before. But this was essentially a training, not a training, research that showed that high levels of counselor relational skills and empathy were more positive for client outcomes. So as we are confident in our clients and show up for them and demonstrate empathy, they become more likely to succeed. And that low rates of empathy can actually be toxic to people's outcomes. So confidence goes both ways. When we believe in people and when we show that unconditional positive regard, it can have positive outcomes for them as well. And then how do we actually do it? What does that evocation look like? Again, hope is a potent predictor of client change, and we can strengthen hope and confidence within a therapeutic relationship. And there are many methods for doing this outside of motivation interviewing as well. There are cognitive behavioral strategies that can help learn new skills or strengthen old ones for coping with situations. There's also strength-based techniques that can highlight and activate change skills that are already present. But for us today here in motivation interviewing, really this idea that hope is evoked from within. As Bill Miller and Stephen Wolnick say, the seeds of hope are already there, waiting to be uncovered and brought into the light. And so MI is personal, it's adaptable, and as we get into everything that comes from here, it's about finding the techniques and strategies that make sense for you and your own style within the spirit of MI. So the next bunch of slides is kind of just going to be a bunch of different strategies and techniques. Some of them might make sense to you, some of them don't. And again, there is no correct way to do this. And so it's really which of these things we're going to talk about makes sense for you, fit in with your own style. How would you see yourself using these things? That's what I really hope you keep in mind as we get into this next conversation.
So we know ourselves better than anyone. We know what works and what doesn't, and the client does too. Since they do know themselves better than anyone, they're the first source of ideas for how change can be accomplished in their lives. So we want to encourage our client to vocalize and to think about their own capability so that they can feel more confident. And the most straightforward way we can accomplish this is by just asking. So we can craft open-ended questions that evoke answers containing that confidence talk and help the client consider how they might shift their routines and lifestyles to make room for action toward change. And we can ask questions like, how might you go about making this change? What might be a good first step? Given what you know about yourself, how could you reduce your cigarette use successfully? What obstacles do you foresee, and how might you deal with them? And what gives you some confidence that you can do this? After the client answers, we can further elicit confidence talk and strengthen hope by following up with some reflective listening. Can you go to the next slide? A helpful tool that we can use to identify a client's confidence in making that change is called the confidence ruler. So a lot of you guys probably have heard of this one. It can be an extremely useful tool for shifting the conversation so that you can talk about that confidence. And then if there's, it's just a great thing to pull out if you feel like there's a lull and it's the right time to make that change in the conversation. The value of the ruler, though, lies in the follow-up questions, and I'll explain a little bit more about that. But the confidence ruler is actually a question. It's an evocative question which asks, on a scale from 0 to 10, how confident are you that you could do this if you decide to? It really doesn't matter what answer the client gives us, but we do want to ask, why are you this number and not a lower number? And we ask that so that we require the client to come up with reasons why their number is as high as it is. It gives them the chance to explain their motivations for why they're not this lower number. And if we reverse this question, it doesn't work nearly as well. It's very different to say, why are you at a 5 and not a 1? Because suddenly they need to defend their reasons for not making the change. If we ask, or I'm sorry, reversed. But this question can just work really well in producing that confidence and getting people to think about what works for them. After we ask that first question, then we can ask, what would it take for you to go from your current number to a higher number? And with that higher number, we want to get like 2 to 3 numbers above whatever the patient answers. So what would it take for you to go from a 5 to, say, an 8? And that allows us to once again probe them to think of reasons that they can make that their confidence higher. So some actions that they can take, some things that might work for them. And if you don't want to add anything, then I'll go to the next slide.
And I just always, the confidence ruler is my absolute favorite thing to use with people. I just think it so beautifully elicits just change talk. If there ever feels like that's something you're struggling to get from people, just the way these questions are designed, it kind of just demands that people give you change talk. It's my favorite thing to use. I just always like to say that.
Giving information and advice. So advice isn't the first thing to offer when we're practicing MI because we really want it to be a collaborative conversation and we want to respect and evoke a person's own expertise. But there are times when people just really are at a loss as to how they should proceed in making a change in their lives. They might not know the answer. They might really need advice. And they may ask us for our own ideas. So when we're doing skillful advice giving, we want to only provide that information and advice with permission from the client, because a lot of people just don't respond very well to unsolicited advice. It's sometimes referred to as the junk mail of life, unsolicited advice. So we want to make sure that we're getting the client's permission. And once we have that, we can provide clients with multiple avenues toward change. Because they tend to respond better when they can freely choose among options as opposed to being told what to do. We don't want to give it one form of advice and expect that to work for somebody. It just might not. When we are giving advice, we can use the framework of elicit, provide, elicit, also known as ask, offer, ask. So this strategy allows us to turn the conversation back on the client and solicit their own ideas first, or ask about things that they've already tried. So we may start by asking, what do you already know about blank? What do you already know about smoking cessation? And that provides the client the opportunity to share the things that they may have already considered, things that didn't work for them, and then also allows us to get a better sense of where they're starting from. Then we can provide information and suggestions to them, after which we want to elicit again. So following up with another question, like, what do you make of all of that? Which one of these options sounds the most realistic or the best to you?
And, excuse me. And, another good way to draw out some of this confidence talk is to help these patients or clients see the strengths that they have within themselves. They may not realize what sort of tools they already have at their disposal. This can be, excuse me, a little bit dangerous because just offering up generic strengths is not going to be useful and can be easily rejected. So it needs to be very specific for the person you're speaking to and personal. Suggesting generic strengths without at least some sort of call to the discussion you've had up to that point can feel shallow and patronizing. For example, you wouldn't want to say, you're definitely focused enough to be able to make this change, because that doesn't mean anything. You could say that to anyone. You'd be much better off if it had been brought up in the conversation to say, your commitment to your family really is a strength of yours and it can help drive you through this. That said, if you've not had a lot of time, or if they are really feeling low on themselves, they may not have brought up any strengths up to this point. And so in that case, you just get straight to it and you can ask them. You can show them a chart if you'll show the chart, Cade. On this long list of positive attributes, can you circle 5 that you feel apply to you directly. And then from there, you can start to have a little bit more of a targeted conversation between yourself and them as you explore what they find to be their strengths to be. And you can explore how that might help them as they try to make this change. Another really strong ability or tool is reframing. If somebody has attempted to stop using some substance or something several times in the past, but always failed, that can really bring them down, as we discussed before. So it can be really helpful to reframe each of those past attempts as not failures, but just that, attempts. Each of those efforts probably involved some sort of success, no matter how minor. And so, discussing that with your patient can help you find out what those small things were. And especially if there's multiple attempts, you can find what worked in each one and maybe put together a coherent plan that can, help them make their next attempt. Yeah, so and then, discussing what was unsuccessful can also really be beneficial if you're discussing contingency management, if you get to that point, later on in the discussion. Just want to be real careful there to stick with the elicit, provide elicit strategies, because you certainly don't want to tell them what they did wrong and how you would do it better.
Yeah. And then another strategy we can use is reviewing past successes. We want to explore changes people have made in the past, have clients go into detail with targeted questions and reflective listening can lead to clients to making arguments for confidence. Questions like, what changes have you made in your life that were difficult for you? How did you do that? Last time you stopped using meth, what did you do that worked? And we want to consider to what extent does the client consider their own role in their past success, exploring why they've decided to make this change, what obstacles did they encounter, and how they were surmounted. This is another opportunity where we can learn about resources, skills, and strengths that they used. Similar to a lot of techniques, we want to learn the things that people have already done. So as we get to that planning section, we can really avoid going over the same type of things that people have already done that may not have been worked, may not have been successful. And so yeah, by reviewing past successes, we can get a really good idea of what has been helpful for clients previously, and also maybe finding opportunities where they may not have thought they had successes, and again, finding those little successes and how we can build on them. Next, we can also use things like brainstorming, where allow the client to freely generate as many ideas as possible for accomplishing change without critique. We would ask them to do this and write them down, and then engage in an exploratory conversation of what ideas seem most promising or acceptable and why. And the purpose of this is to stimulate creative, divergent thinking about how change might be achieved. It is okay as the provider to suggest ideas during brainstorming, but we mostly want to try and rely on the client to bring up the ideas. And as the conversation then unfolds, attend to and strengthen confidence talk through reflective listening, and also just like this, encourage any and all ideas, even things that may seem outlandish, silly, or extreme. Really, just trying to be creative in our thinking and get out of the mindset that it's something that we can't do. Which also kind of gets into the next technique. We can engage in hypothetical thinking, which can free up a client's creativity. Sometimes people struggle with the practicalities. It can be really hard for them to see how they would actually implement something in their day-to-day life. What would it look like? A lot of times with substance use, people can't even imagine themselves not using a substance. That's not something that makes sense in their worldview. They see themselves as someone who uses this substance. And so we can use things like subjective syntax, which sounds like, suppose you did succeed and we're looking back on it now. What most likely is that worked? How did that happen? Suppose that this one big obstacle weren't there. If the obstacle were removed, then how might you go about making this change? Clearly, you are feeling very discouraged. So you use your imagination. If you were to try again, what might be your best way to try? And so all of these statements, they kind of remove the present. They remove the I from statements and just ask them to imagine a world where things are different, things are capable, and then from there we can kind of work backwards and connect that to their present moment and come up with more confidence in solutions from there. We can also engage in an activity like a letter from the future. This is a take-home task for clients that allows them time for reflection. We ask the client to imagine that it is 5 years from now and they have succeeded in making the change that they want to. Ask them to write a letter to themselves from the future, offering words of encouragement about how they accomplished this change, and then have them bring that back in a later session and talk about it, work through the things they came up with. And so for all of these techniques, we really want to have a focus on reflective listening. We want the client to be the one making the argument for change. We know that as we voice reasons for change, we become more likely to commit that change. And we can help do that by supporting and strengthening confidence talk. So remember your ORs, open-ended questions, affirmations, reflections, summaries. And the more time we have with the client, the more time we have to deepen and explore their responses. But even in limited time settings, we can use these techniques to quickly focus in on an area and have a framework for producing that commitment change talk, the taking steps, the activation. And we're coming up on just about the halfway point of the training. We'll move to a break very shortly, and then we'll get into the experiential portion of the training. But just a couple more notes on things. So I'd like to just introduce this idea of radical change with multiple problems. So very often with substance use disorders involves several interrelated problems. It's not just that someone is using meth, it's that someone is dealing with houselessness, they're dealing with an abusive spouse, they're dealing with work obligations, they're dealing with children. Many, many things often become involved with substance use. For example, we can imagine a polydrug dependent sex worker in a city where prostitution is illegal. This person would probably place a high importance on change, but not really see a way to make a change. And it's difficult to talk about changing by only addressing one problem. Sometimes we have to talk about everything in order to make this change. And for someone who has like many interrelated problems, there are many things that change might involve. You know, escaping from dangerous people, finding food and shelter, having to move geographically, drug detox and treatment, resolving legal problems, developing new job skills, finding employment, finding childcare, finding a house. And the question is like, how is this a confidence issue? Why would we be concerned about confidence right here?
I'm not sure. I would say maybe a less confidence means less change.
Mhm. Yeah, clients may not be able to see a way out of this situation, and they may not be able to think that they can change the situation. And even if that idea that it may be important to them, but they just can't see how to do it. And yeah, you know, maybe they can't make the change alone. They may be hesitant to trust their support systems. Very often, especially with substance use, there is a lot of the systems we have in place to help people very often can cause more harm or fail. So there can be a lack of trust going into treatment. But what we want to do is help build confidence to commit to radical change without underestimating the complexity of a problem. And so when we see this, really the way to do this is kind of all these different confidence skills we've discussed can be used over an extended conversation to really understand people in a multifaceted way. We want to understand their strengths. We want to understand what they've tried before. We want to understand why they feel they can't do this, and really get that big picture with people. And once we've kind of elicited confidence in people's broader adaptive abilities, that's when we can start working towards a change plan. And we don't have time really to go over it today, but I can make sure that we send out a really good clinical example showing how we address these complex issues kind of in a conversation and find that radical change, finding a solution that can address all of someone's concerns simultaneously. And before we have a short break, just a quick note on planning. So when we reach the planning stage of treatment, we might expect to hear commitment language. And if we don't hear commitment language, we might expect that change won't happen. This is not accurate. Sometimes we don't necessarily need to hear commitment language for MI to be effective. The client will tell us whatever they are ready to say. And commitment happens when people feel ready, willing, and able. So as we're strengthening confidence and strengthening commitment, planning is that moment where people tell us they're ready to actually do it. So just because we're not necessarily hearing it doesn't mean that that confidence isn't building. And when people are ready, they will let us know. And then when we do move into that planning stage, sometimes things like reluctance come up. And it's important to explore it, not shy away from it. It can feel like sometimes the opposite of confidence and commitment, but we want to address all the reasons, the concerns they still have, and come up with a problem collaboratively. Accept whatever level of commitment they're ready to voice, and just affirm those steps in the right direction. And it's always good to remind ourselves that when we reach the stage of planning, to be really aware of that fixing reflex, continuing to try and evoke solutions from the clients for the obstacles or concerns that they bring up. But yeah, so we'll take a short break, give everyone time to get up, stretch, go to the bathroom, and then everything we'll be doing from this point will be experiential. So let's take 10 minutes and we'll be back at 2, and then we'll do the last half hour of experiential.